Good afternoon, everyone. My name is Alina Dima, and I'm delighted to welcome you to today's webinar, How to Manage Nutrition in Post-Intensive Care Unit Patient on the General Medicine World. This event is organized by the EFIM Early Career Group in collaboration with Spain, namely the European Society for Clinical Nutrition and Metabolism, and I'm pleased to co-moderate this webinar together with my colleagues, Dr. Cristian Kobiliski and Koyal. We are very grateful to ESPEN and its members for joining us today for what it is, I think, a highly relevant and often under-addressed topic in internal medicine. It is a true honor for us to have with us Professor Stanislav Klek, Chairman of ESPEN. Professor Klek is a specialist in general and oncological surgery. He has made a remarkable contribution to the field of clinical nutrition with over 200 publications and has been actively involved in ESPEN for many years. He was also chairman of the international section of ESPEN. Professor Klek, it is a great pleasure and honor to have you with us today. Please allow me to give you the floor for the introduction of this webinar.
Thank you very much, Alina. Good afternoon and probably good morning and good evening because there are so many people joining. I'm really thrilled to be here with you for this webinar. I'd like to welcome you to this webinar on behalf of course, myself, but more importantly, on behalf of the Executive Committee of European Society for Clinical Nutrition and Metabolism. This is a new initiative of two societies. I'm really happy to witness this happening because we have the early career faculty representatives from our society, but also from European Federation of Internal Medicine. That's absolutely great. I'm hoping this is the one of many initiatives actually that's going to take place in the future. And I just wanted to thank you for this effort. Thank you for undertaking this task. And what I'm going to talk about today, so the post-ICU recovery period, and with the focus on clinical nutrition, it's super important. So I think this is also a good moment to talk about it. I wanted to wish you all a great, fruitful meeting. And I wanted to introduce, without further ado, the first speaker, Dr. Imre Kau from Wageningen University in the Netherlands. And we'll listen to the talk about the optimizing care for the ICU survivors. Thank you very much.
Thank you very much, Professor Klek, for the introduction, and thank you to EFIM for organizing this very interesting webinar on ICU survivorship and nutrition. So I won't go much into detail on introduction, but straight go into the topic of post-ICU nutrition. So while we know that during critical illness over the last decades, many of our critical ill patients are surviving, we also see that there is more upcoming metabolic complications during ICU, which leads to poor functional outcome for the longer term. So 7 out of 10 patients suffer from long-term physical problems, which can impair physical functioning, quality of life, but also independence. And we also know that patients suffer from the post-intensive care syndrome, which are new or worsening impairments in physical, cognitive, and mental health. And this really impacts overall quality of life and overall functioning for these patients. So while we know that during ICU, muscle wasting occurs rapidly, up to 20% in the first 10 days of critical illness, muscle wasting continues to occur during recovery from intensive care unit stay, with poor functional recovery happening up to 5 years even after ICU discharge, and patients after 6 months after ICU discharge still have facing health-related problems. Almost half of the ICU survivors still have health-related problems or have returned to work 6 months after leaving the ICU. So this is a dramatic problem. And we know that nutrition is part of our standard clinical care during critical illness. We also know that it is important and central to recovery, mainly due to minimizing the loss of physical function, but also in regaining mental and physical strength. And there's nutritional guidelines from ESPEN, but also the American Society for Nutrition Prescription during critical illness. But if we look into the nutritional guidelines following ICU discharge, there is no international guidelines established yet. But the post-ICU phase is a very complex and important phase where we could intervene with nutritional interventions. The post-ICU phase is characterized by the underlying disease, which was causing the life-threatening condition why patients were in the ICU, but also the physiological impact of the survived critical illness. Metabolism during recovery from critical illness is probably changing when patients leave the ICU to the post-ICU phase as well. During ICU, patients show anabolic resistance, so a reduced capacity to respond to dietary interventions, in particular protein. However, during the post-ICU phase, there might be a more anabolic capacity for patients to respond to nutrients. We also know that energy expenditure increases and metabolic requirements increase, but there's high individual variability. So the exact energy requirements are still unknown in the post-ICU phase. For protein, we think that recovery of functional mass and prevention of further loss of muscle mass and strength, protein is important. However, there's no post-ICU protein targets, and mainly guidelines are used for older adults or hospitalized older adults that prescribe protein intake of more than 1.5 grams per kilogram per day. But post-ICU nutrition is complex and under study. There's only a handful of studies that looked into nutritional intake in the post-ICU phase, but also post-ICU care pathways differ per country, per hospital, per institution, and that's why it's complex to really compare post-ICU studies in terms of nutritional recovery. On the other hand, the post-ICU phase is a window of opportunity. While interventions during the ICU mainly focus on the acute phase, really to reduce metabolic complications in the acute illness phase, we're aiming to improve longer-term outcomes over months to years after leaving the ICU. So there's a huge window of opportunity to intervene through nutritional interventions and recovery strategies. And we talk about post-ICU nutrition. This involves medical nutrition. Patients leaving the ICU probably sometimes still have enteral or parenteral nutrition ongoing, but also oral nutrition or a combination of both. On the other hand, on the ward, hospital meals are mainly primary intake, with differences in hospitals' food service systems and also differences in preferences of patients. Then when leaving the hospital, patients are often discharged to rehabilitation centers or home. And here another complication takes part because of preparing own hospital meals or being dependent on nutrition that is prescribed in a rehabilitation center, for example. So post-ICU nutrition compiles of all the different aspects. But what do we know on the amount of nutritional intake in the post-ICU phase? There's been a couple of studies that looked into protein intake during the post-ICU phase on the general ward. And while we know that in the ICU up to 60 to 70% of adequacy is reached, leaving the ICU on going to general ward, there's a big window or difference between the amount of prescribed energy and protein targets that are being met, ranging from 30 to 75% of prescribed energy and protein targets. Also, we see that oral nutrition alone or the combination of enteral nutrition with oral nutrition is the most predominant mode. And this is one of the first studies really looking into nutritional intake that quantified nutritional intake in post-ICU patients from Leanne Chappell from Australia in University of Adelaide. And she showed that in traumatic brain injury patients, energy and protein deficits were much greater on the ward than in the ICU. So while targets were met during the ICU or just being met on the ward, this dramatically dropped. And it was almost a twofold greater deficit in patients that were dependent on exclusive oral nutrition. So this is probably the group that has the biggest risk for nutritional deficits. And this is work from Emma Ridley, also from Australia, from Melbourne. And this is an observational cohort study in around 30 patients that followed post-ICU patients up to 28 days after leaving the ICU. And she showed that the largest deficit in energy and protein intake is in the group that consumes oral nutrition without oral nutritional supplements. And the group being prescribed with enteral nutrition and oral nutrition, the highest targets were met. So again, a very high risk for patients being dependent on oral nutrition without any supplements being described. But why are not always supplements being described? What do we know on nutritional therapy on the post-ICU phase? There are studies and also a study from our group showing that there's a difference between the ordered and the consumed amount of prescribed nutrition. Up to 30 to 40% of meals that are being ordered are not being consumed. So it's important not to only look at the amount of ordered nutrition, but also the consumed amount of nutrition. On the other hand, a big Nutrition Day audit in post-ICU patients from Arabella Fisher published a couple of years ago showed that not all patients are receiving any nutritional therapy. Up to 50% of the post-ICU patients that were eating no meals or dependent on enteral that were not consuming their meals received nutritional therapy. And 32% of patients eating less than half of a meal only received nutritional therapy. So I think still a lot of patients are not being basically seen or not being warranted for nutritional therapy. And this is a study also coming from Melbourne looking into nutrition care processes following ICU discharge. And here you see that on ward and in rehabilitation centers, patients are still highly dependent on high energy and high protein diets. And also soft diet or textured modified diets are still very much being prescribed. And interestingly, the length of stay was longest during acute ward and rehabilitation centers. But the lowest amount of dietitian visits were actually taken place in rehabilitation centers. So while the longest length of stay is in these destinations, the lowest dietetic care is basically being prescribed. But why is adequate post-ICU intake so challenging? So this has been summarized in a couple of reviews, and one of the research coming from our group, really showing that there's different factors being involved in post-ICU intake, making it a very multidisciplinary and very complex part. We have patient-related factors that impact poor appetite, satiety, nausea, and vomiting, but also change in taste of smell and functional problems related to, for example, mechanical ventilation during ICU, but also mental health disabilities such as sleep disturbances, depression and anxiety impacting intake. On the other hand, also organizational and healthcare system factors, which I will elaborate a little bit upon later. So nutrition impacting symptoms have been described by a couple of studies. The most reported barrier to eating post-extubation in post-ICU patient is poor appetite. More than 80% of patients report having a poor appetite, and still 40% having a poor appetite at home or at hospital discharge. Other nutrition impacting symptoms that have been reported a lot are early satiety, fatigue, nauseousness and vomiting, and taste and smell changes. Swallowing difficulties and dysphagia have been reported in up to 75% on the ward and at home, and this also involves modified texture and fluid diets. However, they have been associated with reduced energy and protein intake. Fatigue, low quality of life, and mood and weakness is reported most. More than 95% of patients report to have fatigue. And this is also associated with the reduced ability of independently eating, so needing a lot of feeding assistance. Interestingly, only 1/3 of patients that are 44 years or older that have been on the ICU for 2 weeks or longer showed that they were unable to feed themselves independently even 6 months following ICU discharge. So this really highlights also the effect of maybe not even being able to eat and reduced ability of independently being able to consume meals. So we recently performed a study looking into food preferences in both post-ICU patients on the general ward and general ward patients, as we were interested to see whether there are differences in food preferences or self-perceived appetite, taste and smell in patients that were leaving the ICU and admitted to the general ward, or patients that were just admitted to the general ward. We used questionnaires within 24 hours of ward admission in both groups, 7 days after the first questionnaire or at hospital discharge, and we called them 6 weeks later to report on self-perceived appetite, smell and taste changes. And we included 50 post-ICU and 50 general ward patients. And here you see on the top panel the general ward patients, on the lower panel the post-ICU patients. There were no differences in appetite, taste, or smell perception at ward admission. So patients coming to the general ward having no differences between being at the ICU before or just being admitted from home or another ward. However, post-ICU patients significantly improved appetite and taste and smell throughout the 6 weeks following recovery after the ICU, while general ward patients only appetite improved. And in the post-ICU patients, we saw that sepsis and mechanical ventilation was associated with reduced appetite and taste perception at ward admission. And then we quantified nutritional intake in those two patients group, and we saw that post-ICU patients still had a lower energy and protein adequacy from oral food intake than general ward patients. However, when we associated it to any of the nutrition impacting symptoms, only the influence of surroundings was associated with reduced nutritional goal achievement. Another observational study from our group, we looked into food intake in post-ICU patients that were dependent on enteral nutrition during ICU. And we did that by using photos of their meals. So patients were taking photos of their meals pre and post consumption so that we could quantify food intake. And we were interested to see the amount of enteral, oral, and parenteral nutrition that was being consumed in the post-ICU phase. Again, we saw that around 25 to 30% of energy and protein was not consumed. And this is protein adequacy in this group, where we see that when patients left the ICU ward, so going from day -1 to day 1, day 1 is the first day on the acute ward, we saw a drop in protein adequacy on the right, up to 60% in protein adequacy on day 1, and up to 80 to 90% on the following days in the acute ward. However, this was when the enteral tube was removed. We saw a drop of 40 to 50% of energy and protein intake when the enteral feeding tube was removed. And the reasons for enteral tube removal, when we asked, was basically patient self-removal, the supposed sufficient intake, which led to removal of the enteral feeding tube by clinicians, patient refusal, or per clinician request. So removal of enteral feeding tube is a very important part of the nutritional deficit that we see in post-ICU patients. Some other organizational and healthcare barriers that have been prescribed is the lack of continuity of nutrition care. Survivors of critical illness are treated as other hospital patients. The transition of feeding mode, so no appropriate assessment of oral nutrition adequacy or the belief that oral intake will increase. The lack of education in staff, patients, and their families. Multidisciplinary care, so no dietitian involved, or system-related factors such as hospital food service, portion size, food access, and cultural habits. And survivors of critical illness have reported nutrition screening and counseling to be essential for recovery. However, they also reported a lack of availability or accessibility to multidisciplinary healthcare systems or community-related systems after hospital discharge. So it's more than just nutrition impacting symptoms, probably also some organizational and healthcare barriers. So finally, I would like to highlight a couple of studies that looked into some studies to improve nutritional intake in ICU survivors, which are only a few up till now. So we followed the Prospect 1 study up with the Prospect 2 study, which has recently been published. And what we did here, we aimed for an individualized protocol where patients were instructed to take photos, again with a tablet of their meals, and we quantified a nutritional intake from oral meals from the day before. And based upon the oral intake that patients were consuming, we tapered the amount of enteral nutrition that was still prescribed, as shown in the figure here. Patients were aiming to reach protein intake between 90 and 110%, and when this protein adequacy was met, we could lower the enteral nutrition prescription. All the way down to when oral nutritional supplements were being prescribed in addition to oral intake, and when patients still met between 90 and 110%, they had to show for another day that they were able to consume 100% of their prescribed protein intake before that feeding tube was removed. So these are the findings of our study. We followed patients up leaving the ICU with a feeding tube still in situ, going to the ward. Up to 70 patients were included. And we were successful in reaching energy and protein targets up to 100% for the first 14 days after leaving the ICU. Here you see in the black line as well that we were successful in tapering down enteral nutrition. However, not in all patients we could totally taper down enteral nutrition. In the patients that were successfully transitioned to exclusive oral nutrition, that was only 70% of the total group, we still reached 80% of energy and protein targets. However, the duration of enteral tube feeding was a bit longer in these patients, but when the feeding tube was removed, the intake adequacy only dropped by 26 to 28%, which was up to 40 to 50% in the Prospect 1 study. And still, patients where we removed the feeding tube according to the protocol, this was only 22%. There were also still a group that were not able to completely wean off enteral nutrition, or that the enteral feeding tube was removed before finishing the protocol. And another nutritional intervention that has been published by Emma Ridley. This is the INTENT trial, which was an international multi-center trial over 22 hospitals. And they aim to look at an intensified individual nutrition randomized controlled trial, where patients were receiving daily dietitian counseling, aiming to increase energy and protein delivery in post-ICU patients. And they also showed that when a daily individualized nutrition protocol is applied, a difference of almost 300 kilocalories per day could be met between the intervention group and the usual care. However, they had not enough power to look at any clinical outcomes or any secondary outcomes, such as physical functioning. So to conclude this talk, I hope that I convince you that the catabolic effects of ICU and prolonged inadequate nutrition dramatically impact post-ICU recovery, and that there's a window of opportunity later in ICU stay or in the post-ICU period where nutrition interventions are important, as we have a longer duration and we aim to impact long-term outcomes. However, there's a tailored patient journey. We need tailored nutrition intervention and an ongoing assessment of nutritional status and monitoring oral food intake to really make sure that oral food intake adequacy is being met. The avoidance of premature removal of gastric tube is important to limit inadequate oral intake, and the combination of oral with enteral or oral nutritional supplement diet is probably the highest opportunity for higher energy and protein intake. A multidisciplinary approach is important to lead detailed handovers between the ICU to the ward, but also from the hospital to at home, the assessment of oral nutrition adequacy, and the prescription prior to removal of enteral feeding tubes. Co-designed intervention and family engagement is very important and might help to improve nutrition care in post-ICU patients. And with this, I would like to thank all the people working in our ICU research group in Wageningen University in Gelderse Vallei Ede in the Netherlands, with our PhD students doing all a tremendous amount of work in all these post-ICU studies that are very complex, and all the sponsors that are funding all our work. Thank you very much.
Thank you very much, Imre. We will take all the questions at the end, so please feel free to submit them in the chat as we go. Now it is my pleasure to introduce Dr. Ricardo Marinho. He's a specialist in internal medicine and intensive care in Porto, Portugal, in San Antonio Hospital. Ricardo, the virtual floor is yours, please.
Thank you for your introduction and thank you for the invitation to participate in this webinar. As I said, I work in San Antonio in Porto. This is my virtual hospital, and I am also part of the Portuguese Pen Society and from the clinical nutrition group of the Internal Portuguese Medical Society. So my talk is about applying EFIM guidelines in internal medicine and some practical strategies for the nutritional support. First of all, I would like to state, like the previous staters, that there are no guidelines about post-ICU periods, not the most specific guidelines of the European or the American guidelines for intensive care. So I will have to adapt to more general guidelines about geriatrics and the polymorphic medical intake for this talk, and tweak the guidelines so they can better adapt for the post-ICU period. Because there are no guidelines, there have been created a consortium to further study the post-ICU gap, mostly about nutrition. That is the GRIP consortium. They published at the end of last year thesis article showing all the core research domains that must be further evaluated. And one of them, as you can see, slide, is the education and the healthcare professional engagement. That is one part of this webinar, and I thank you all for coming and assisting. So, as I already said, I'm going to tweak the polymorphic medical inpatient guidelines. This is one of the main graphics of guidelines. They talk about the nutritional screening, then personalization of support, nutritional targets, the routes, how we are going to give the nutritional support, and then monitoring and the continuation of discharge. So our learning objectives will be to identify the main nutritional risks of post-ICU patients. That is a continuation of the previous talk that was more extensive. This is a little shorter. Then we'll see the targets, the caloric and protein targets, then the routes that we have to choose, and then come to some common board barriers that were also previously mentioned. As stated, all the patients that stay in the ICU for longer than 48 hours are in nutritional risk. So we can simplify things. There's a special group, and we have to treat them. All the patients that stay in the ICU for longer than 48 hours need nutritional treatment after the ICU because of the persistent hypercortisolism, because of the muscle waste that they suffered, the anabolic resistance, the prolonged immobility, and then the inadequate oral intake because of swallowing issues and also the symptoms that are caused by the experience in the ICU. So joining all factors, almost every patient that are in the ICU are in nutritional risk, and most of them are already malnourished and carry a huge nutritional debt to the general ward. And usually there's a gap in nutritional care that we must tackle, and this is the part that I'm going to strain in this talk. As I state, the first part is nutritional evaluation. If you see almost all nutritional screening tools, I mentioned that intensive care patients, like in ERS 2002, give a huge score, and only with the intensive care patients, only with that they score a 3, so they are in nutritional risk. So every patient are in nutritional risk, so you can skip the nutritional screening part and go right to the nutrition evaluation or nutritional assessment. For this, as I'm talking about EFIM, I suggest the green criteria. So in the green criteria, there's screening part that's already done. Then we're going to do the diagnostic part. In the end, half of it is already done. Typical criteria and one etiologic criteria. In the etiologic criteria, in most ICU patients, both of them are already checked, inflammation and reduced food intake. So we'll need to see the phenotypic criteria. How many weight patient has lost since he has entered the hospital, or previous, if we know from last month. The BMI, it's not really useful in this part, and how much muscle he has lost during the ICU stay. he can contabilize doing ultrasound, CT scan, BIA, it's great. If not, we just have to acknowledge that he has lost muscle and we have to address it. So, and then if you want, we can try and grade of malnutrition moderate severe. It's more a long-term target, so the patient can recover full functional capacity, but the initial therapy is most likely the same. So, about nutritional targets, there are no guidelines. So, joining some review articles, the medical in patients and the geriatrics art guidelines, the most common issue is about 25 to 30 kilocalories. That's it's same for all of them. About the proteins, I'm a bit more ambitious. Here in the paper, they talk 1.0. In the polymorphic, they talk 1.2 to 1.5, and geriatrics, they talk over 1 gram. But, well, patients have lost a lot of muscle, so they will need a lot more protein. So the target of over 1.5 and usually 1.5 to 2.0 grams of protein per kilo per day, usually a very good target that is very hard to achieve, but we need to point higher so that we can try and achieve it and for the best of our patients. So for nutritional targets, simple 25 to 30 kilocalories per kilo per day and protein 1.5 to 2.0. About the feeding routes, as you know, we have oral, enteral, parenteral. As we've seen in the previous talk and getting some of our slides, we see that the patients, when they're only in oral nutrition, it's not enough. Most of them get around 50 to 70% of the nutritional targets, either by caloric, either by protein. So we need, in most cases, to do a combination. One of the most common combinations, enteral with oral, oral with ONS. That's what I'm going to further explore. Starting with, again, with the guidelines. The guidelines, they defend oral nutrition, and then if they don't achieve the nutritional target 24 to 48 hours, go to enteral plus oral. And again, if they don't achieve it, go to parenteral with oral and enteral. I would like to add some remarks regarding this. Regarding if the patient doesn't have an nasogastric tube when they get to the ward, oral nutrition alone is not enough. We have to optimize normal food with fortified menus, with texture adaptations, with assistance with meals. The patients usually have some functional deficits, so a nurse or a care taking, giving, and supporting with meals, it's very good. Also, the meal times must be protected. If the patient is interrupted during meal times, if the patient has exam during meal times, they will skip a meal. And the meal in this part, it's very important. It's sometimes more important than other drugs. So the meal times must be protected. And for some reason, they must have an exam, the meal must be saved for the patient to consume after it. So protect meal times and don't bother your patients during the meal times. It's not the time to do follow-up questions, to do physical exams. No, during meal time, it's a sacred time. The patient must be alone. And also have scheduled snacks to further improve. And alongside with it, have always oral nutritional supplements. Normal food is never enough. At least give 400 kilocalories and 30 grams of protein in oral nutritional supplements. But choose carefully when to give these supplements. Never give them near a big meal. So in the morning, afternoon, and then ideally after dinner before going to bed, so that they can follow up all the oral nutritional supplements and don't influence the other meals. If that's not enough, that is usually the case, you have to go to enteral nutrition. But don't think of enteral nutrition like we think in the ICU ward. Most of it is also by nasogastric tube, but think about continuous feed for 24 hours. Don't get the patient in the bed during the 24 hours. Do bolus feed or intermittent feed so that patient can have some rehabilitation, can get out of bed, can walk, can enjoy their life, and not being stuck in the bed. So that you can give the nutrition that the patient needs, but also protect their autonomy so they can further improve their autonomy. And when it's not enough, you can go also back and remove the nasogastric tube and also maintain only normal food. And that is, if this is not enough, join parenteral nutrition. And again, don't think like we think in the ICU with a central venous line and with total parenteral nutrition. No, think about it as a supplemental parenteral nutrition. So the patient is eating, it's not enough. You can give a small bag of parenteral nutrition so that we can give them a boost. And if it's a small bag, it doesn't need to be a 24-hour perfusion. It can be a 12 hours or even a 6-hour perfusion. You can do the parenteral nutrition during the night so the patient doesn't get stuck in the bed during the infusion of the parenteral nutrition. And this is a step-up approach, so the patient doesn't have anything and you increase. But if for some reason you can give enteral nutrition, if the patient refuses nasogastric tube or so on, you can skip it and do oral with ONS plus parenteral nutrition. So it's not a clear route and clear escalation. If we have to skip it, just go for it. And if the patient, when you reach the ward, has a nasogastric tube, don't do a step-up approach, do a step-down approach. So if the patient has a nasogastric tube, maintain nasogastric tube, maintain the enteral feeding, and reduce enteral feeding alongside with the increase of the oral nutrition. And usually, as previously stated, oral nutrition alone is not enough. You need oral nutrition with ONS to reach the targets that we need, as previously stated by the author of this article. This is also repeated slides, but I think it's a very important one. So after we evaluate the patient, after we choose targets, after we try and go by its route, maybe there are a lot of barriers. The patient factor, functional factor, psychological factors. The psychological part, it's very important. The patients usually are depressed, sleep disturbances, the pain, fatigue, and treatment of the symptoms, it's very important. We've all been sick, now with COVID pandemic and all, and we all saw that during our sickness, our ability to eat was very reduced. But if we do like a palliative care approach, to not focus only in the disease and focusing on the patient and the symptoms that patient has, we can improve their quality of life. And if the patient feels better, they will eat better. So the anorexia, the illicit satiety, nausea, vomiting, the depression, everything, we have to tackle each one of them individually so that the oral part of the oral nutrition will improve and we can reduce everything else. Also, as always, we have to do a swallowing test, see if the patient has oral dysphagia or not, see the muscle loss that he has, do the rehabilitations, and as I said previously, the organization factors are important. We have to see that the meals arrive in the correct time, that meals are hot and are packable. I'm not sure about you, but in my household, the meals sometimes arrive already cold, and their visual effect is not very good. So if we can improve it, people will eat better. Again, the early removal of the interior feeding pump to see that it's not removed too early, and then again the healthcare system factors like the lack of nutrition knowledge, the poor handover. It's very usually focus a lot in the handover of the diseases and the problems that the patient had, but the nutritional support is usually not one of them, and most of nutritional support is lost during the transfer. So you have to get in mind that. And one thing is the prescribed nutrition, the other thing is the absorbed nutrition. And there are a lot of steps and there's a lot of barriers that influence that. We can prescribe nutrition, so we do the calculation, we prescribe, we choose route, but then there are interruptions for exams and procedures, there are feeding delays, there are errors, there is premature tube removal, the tube dislodgement that can reduce the prescribed to the delivered nutrition. Then, from the delivered to the consumed, there are poor appetite, anorexia, nausea, vomit. Patients may have some refusal to eat, some food aversion, some following issues that can reduce the delivered to the consumed. If after the nutrition is consumed, there can be some gastrointestinal problems like ileus, vomiting, high residual volume, some kind of malabsorption that can reduce from the consumed to the absorbed. And after that, only a small part of the absorbed nutrition is used for rehabilitation. We have to have enough physical support and enough mobilization and muscle stimulation for muscle to improve. And then in this part, we have to remove the anabolic resistance. We have to remove the inflammation and the metabolic stress so that the organism is ready for recovery and not to fighting against the disease. Joining all of this, and in some part of conclusion, when we receive a patient from the ICU, we have to take the patient history and treat the symptoms that the patient has, so that their status is the best that it can be. Then you must do a nutritional screening and assessment. All post-ICU patients are weak, so I suggest evaluating directly with the GLIM. Then do a dietary assessment, calculate caloric and protein needs, evaluate the swallowing capability, then choose the feeding route. Oral and is always the first, but we can mix. You can start oral with ONS, oral with enteral, oral with parental, enteral with parental. We don't have to follow a schedule line. Each patient is one of a kind, and we have to adapt it for each patient. There are patients that prefer not having a nasogastric tube and having a central line or a midline, and do parenteral nutrition instead of doing enteral nutrition. And also think, in enteral nutrition, you can do bolus feeding or intermittent feeding, and in parenteral nutrition, you can do also intermittent feeding during the night, so that the patient uses the daytime for rehabilitation and for cognitive practices, all of it. Then we have to monitor intake daily. That's usually the nursing part, but we have to train all the team, so that we are all on board and escalate if targets are not met and create a multidisciplinary approach to this. Because only with nutrition and the mobilization and the monitoring, the patient has the potential to fully functional recovery. And as already stated in the previous speaker, this is a long process. It doesn't finish in the ward. It continues to a rehabilitation center or at home. So the nutritional plan must follow for ambulatory care. And I always defended that if the patient starts ONAS in the ward, it must continue to the home for at least 1 month. I usually defend 3 to 6 months. And as the geriatric guideline states, give at least 400 kilocalories per day and 30 grams of protein in order to do a continuum of care and not have such huge gaps between each step. And that is my talk. Here is my email if you want to have some, if you want some kind of support or some kind of doubts, I'm always available. And thank you for this kind introduction and for joining us.
Thank you, Dr. Ricardo Cleto-Marino, for your insightful presentation. Your expertise definitely resonated with our delegates, and question and answer session will be at the end of the webinar. Thank you, Dr. Ricardo, once again for enriching us. Thank you. So we are moving forward. It's my privilege to introduce Dr. Anna Simona Salstelli, one of the stalwarts in our medical nutrition fraternity. Welcome, Dr. Anna. She has completed her MD and PhD and currently associated with Center for Chronic Intestinal Failure, Santa Sola Hospital, Bologna, Italy. So welcome, Dr. Anna, and over to you. Thank you.
Thank you all, and thank you very much for involving me in this kind initiative. It's always a pleasure to be my little part, to do my little part in these very interesting initiatives. So let's start with the presentation. I think you all can see the screen. And let's start talking about what are the nutritional intervention for older people in the general medical ward to see the best for our patients. As in any other field of clinical nutrition, the EFIM guidelines could be a very clear guidance and a reference for clinical practice. So in this case, the EFIM guidelines state that healthcare professionals as well as informal caregivers should be aware of the risk of malnutrition or of malnutrition itself for older people. And so they should always have a basic knowledge on nutritional problems in order to avoid any issues relating to nutrition. Actually, as you already heard, older people could have more than one reason to be at risk of malnutrition or to be already malnourished. This could be chewing problems, swallowing problems, serious stomach, problems related to mobility and to self-sufficiency. For example, preparing meals, going to shopping and cooking, going to the toilet alone, for example, and also psychiatric disorders, so depression, anxiety, that of course are a very big obstacle to proper nutrition. And so it's mandatory that all older people, independent of diagnosis and including people with overweight or obesity, shall regularly be screened for malnutrition with a validated tool in order to identify the patients at risk of malnutrition or patients already affected by malnutrition. And if the screening is negative, so the patient is not at the risk of malnutrition, the screening should be regularly reassessed depending on the characteristics of the patients. But if the screening is positive, so the patient is at risk of malnutrition, then a proper nutritional treatment should be prescribed for prevention and treatment of malnutrition. But why it's so important that older people and all people in general are screened for malnutrition? As we all know, when there's a disease, a medical and a surgical therapy are prescribed for the best clinical outcome. But a disease very often could develop to the onset of malnutrition, and this can worsen the clinical outcome. The consequences are an increase on mortality, morbidity, length of hospitalization and costs, and a decrease on quality of life. But a proper nutritional therapy could prevent and treat malnutrition in order to avoid all these issues. For the screening of the older people, the tool validated that should be used is the Mini Nutritional Assessment, MNA. There are various versions of this tool, and the most used is the MNA short form. So as you can see at the top, there are the data of patients, and then follows 6 items regarding the reduction of the oral food intake over the past 3 months due to loss of appetite, regarding the involuntary weight loss during the last 3 months, regarding problems on mobility, the presence of psychological stress or acute disease in the past 3 months, the presence of neuropsychological problems, and data related to the BMI, and if BMI is not available, data regarding colon circumference. People should answer these 6 items in a very easy way, grading their answer from 0 to 2 or 3, depending on the gravity of the situation described. And at the end, there's a final score. If the score is between 12 and 14, so it's a high score, people are not at risk of malnutrition because their nutritional status is normal, and the screen just could be provided regularly depending on the condition of patients. If the total score is included between 8 and 11 points, the patient is at risk of malnutrition. And if this total score is below 7 points, so included between 0 and 7, the patient is malnourished and a nutritional therapy should be prescribed. What are the first steps to improve the nutritional therapy for this patient? Of course, meal support and eating support would be improved with social interactions, with suitable mealtime environment, with, of course, mealtime assistance. In institution, it would be possible to create a home-like, pleasant dining environment, and are also very important verbal and physical support to it from healthcare professionals and also caregiver. Every patient should receive nutritional counseling that should be individualized with the use of fortified food, so extra nutrients added to food, for example, vitamins, iron, or calcium, or fortified diets, which means that additional nutrients have been added through foods such as cream, butter, milk, and milk powder in order to increase nutrient density without increasing the portion size. It's always good to suggest additional snack or finger food. If there are chewing problems, it's important to modify the texture of food, of course. And even in presence of overweight or obesity, it's not suggested to prescribe weight-reducing diets in order to prevent loss of muscle mass. Between and together all these dietary intervention and dietary suggestions, the use of oral nutritional supplements is very important. They could be liquid, creamy, powdered, depending on the need of the patients. They could have a different amount of calories and proteins. They are disease specific, so for diabetes, kidney failure, liver cirrhosis, for example. And they could be also isolated macronutrients, so just proteins or just carbohydrates, or in the form of thickeners in case of dysphagia, for example. They differ for the amount of fibers that could be soluble or insoluble. They could be lactose-free, and the lactose should be also present, but in irrelevant amount, so they are always well related. They often are gluten-free, and they differ for osmolarity, so they could be isosmolar or hyperosmolar. for the energy provided, so they are hypocaloric, normocaloric, or hypercaloric, and also about the amount of the protein provided. So a normal amount is about 15% of the total calories, and if the ounce used is high protein, it provides equal or more than 20% of total calories. To be effective, a oral nutritional supplement should provide at least 400 kilocalories per day and at least 30 grams of protein per day. The efficacy should be assessed once a month, and because ONS should be continued for at least 1 month. Compliance of patient, that is not always easy, has to be regularly assessed. And of course, they have to be adapted to the patient's eating capacities and difficulties. ONS could be a very important tool to prevent or treat malnutrition. This recent review stated that in older hospitalized people at risk or with malnutrition, oral nutritional supplements may reduce mortality and serious adverse events compared to control 30 days after randomizations. Another important issue for older people is the risk of dehydration, and particularly for low-take dehydration. So the fluid needs for this patient is included between 20 and 25 milliliters per kilogram, to be increased in case of fever and gastrointestinal disease, for example. So it's always very important to encourage people to drink, to frequent offer drinks, to be aware of the need of adequate fluid intake for this patient. And it's always important to provide adequate support in taking adults to the toilet quickly when they need, for example. And when it's diagnosed condition of serious dehydration, together with the encouragement for oral drinking, a subcutaneous or even better intravenous fluid should be provided. But when all these suggestions, including food, dietary interventions, and liquid, are not enough to compensate the nutritional need of the patient, and if the oral intake is below half energy requirement for more than 1 week, then enteral nutrition should be provided. So a kind of nutrition that is delivered via feeding tubes. It could be short-term with the nasogastric tube or nasojejunal tube, or long-term enteral nutrition with the use of a gastrostomy or jejunostomy. The formula for enteral nutrition shares some characteristics with ONS. So they are gluten-free, they have an irrelevant amount of lactose, they could have fevers or not, they differ for osmolarity, energy, and they are divided in polymeric or oligomeric, depending to the characteristics of the proteins and the carbohydrates including. The most used are polymeric, because they could be also palatable and could use for the progressive improving of patient during all the nutritional therapy. Just some clues about enteral nutrition that could be continuous or intermittent. There's always needed a feeding pump to deliver the nutrition in a safe way for the patient. It should start slowly and then progress up to gastrointestinal tolerance. And the infusion line management should be also with clean and aseptic procedures. As we heard, enteral nutrition could be also long-term. So we talk after discharge about home enteral nutrition. But if the patient or his or her caregivers do not give consent to home enteral nutrition, then home enteral nutrition should not be offered. And in this case, it's important to provide parenteral nutrition. So to conclude, older people are often at risk of malnutrition and dehydration. Validated screening tools should be performed to assess the nutritional risk. Nutritional strategies consist on dietary interventions and oral nutritional supplements, and enteral nutrition should be offered if dietary intervention don't reach the nutritional needs, but it could be not accepted by the patients or caregivers. In this case, it's important to provide parenteral nutrition. Thank you very much for your attention.
Alina speaker is not on.
Your microphone is off, Alina.
Sorry, I'm very sorry. Sorry. So, thank you very much, Dr. Sasdali, for this excellent presentation on nutritional strategies for older adults and for highlighting the evidence-based approaches that can truly improve our patients' outcomes. We will now move to the discussion part of the webinar. I would like to invite Professor Clerc and our moderators, Christian Kobylinski, and to start the discussion and address the question to the speakers. And there's also some questions, I think, in the section.
I think we should start with the question from the audience. I think there is a question for Ricardo. What is your experience regarding supplementary PN while gastrointestinal tract is functioning? And to what extent is crucial?
Well, so we can use PN is so that the system is working not an contraindication for translation. I usually of supplementation, a lot of high volume and full position in kind of function. So I usually also the and also just do a supplemental nutrition, and we do supplemental nutrition about it. I think that we have to think there are types of correction. They are parental only for central lines, using proof. It's in the of this right. You can use supplemental nutrition.
We cannot hear well now, Ricardo. I don't know. I think it is the technical team sent me that it might be a problem with the microphone. The microphone.
Ricardo, we cannot hear you. Probably we should move to another question. And I think this one is addressed to Anna Simona. How frequent do you perform nutrition screening?
Well, nutrition screening should be performed regularly when the patient enters the guard and regularly, so every week or every a couple of days, depending on the characteristics of patients. I work in a nutritional unit in hospital, so it's my work to perform a nutritional screening, and I do it very often. But the message is for the other colleagues that do not prescribe nutritional therapy in the regular activity. So the ESPEN guideline and the guideline in general suggested to perform this kind of screening at least at the entering of the patient in the guard, and then to continue for all the staying of the patient in the guard until the discharge.
And also for you, Anna, what weight is used to calculate milliliter of liquids?
Milliliter for liquids for older adults is, as I showed, for between 20 and 25 milliliters per kilogram. But if the patient has fever, has, for example, a high output stoma or a high output fistula or diarrhea or vomiting, this amount should be increased according to the balance, so monitoring the urinary output and the other losses of the gastrointestinal tract. So we can keep in mind this value, so an amount between 20 and 25 milliliter per kilogram, and this is of course to be adapted to the characteristics of patients.
I see that Ricardo is back.
Yes, sorry, I don't know what happened to my mic. I'm not sure in which part of my answer was cut off. Sorry.
Don't worry, we have another question for you. I think if the patient didn't agree to home enteral nutrition, what is the procedure and indication of PN? So a similar question. We we can hear this answer.
So one thing is parenteral nutrition in the wards when we have trained staff to it, and the other is to parenteral nutrition in the ambulatory setting. It's very different because you need a support team around it, and it usually depends in which country you're on. There are countries with a huge support for it, and it's very easy to do parenteral nutrition in the ambulatory setting. And for most of our countries, it's almost impossible, if not impossible, difficult to do parenteral nutrition in this setting. So we usually only recommend it for patients with severe intestinal failure that can do it. Okay. Can you continue to the next?
Thank you. For Imre, I think we have a question about the ICU. How to deal with the nutrition in an ICU patient on continuous catabolism phase, so a typical critically ill patient. How much and how to provide nutrition, Imre?
So this is during the ICU phase? So
yes, during the ICU, I think.
So what we do is, given a recent large RCT showing that very high protein nutrition might not always be advantageous or maybe even harmful, we don't progressively feed high protein. But again, this is really based upon all the latest large RCTs. And I think there's more and more research showing that indeed catabolism is a very big problem. However, we also see that there's anabolic resistance, so patients don't really respond to the amount of protein that we provide. So we are usually a bit tempered in providing protein in our ICU. However, I think that when patients are more able to use the provided protein, however, we don't know when this is, then there might be room for increasing protein doses. But still, doses up to 1.3 or 1.5 is really the max where we would go on in the post-ICU ward. I think there's not a lot of evidence to really provide more protein during the post-ICU phase either. This is all still very hypothetical driven.
And how much protein must be recommended for patients with AKI and CKD along with hypervolemia condition, so patients with renal dysfunction?
So we see in the large RCTs, such as the effort protein, and that the AKI patients were the one that showed harm of high protein feeding. So again, I think this follows my previous answer that we should not feed too much protein, but what that exact amount is and that there is a U-shaped model for protein provision, that is still to be established. So yeah, I would just leave it there.
And would you prioritize hypocaloric, high protein feeding initially post-ICU?
Yes, I think we mainly prioritize for protein over energy. And I think we should not forget that we all want to give more and more and more, but I really hope in my talk that I also showed that just providing more is not really what patients can consume. We recently published a paper where we see that there's a kind of upper limit for the amount of energy and protein a patient can consume on the ward as well. So I think it's more than just providing more nutrition. We should also be a bit more smart in providing it throughout the day, or maybe providing more mobilization as well, or maybe in terms of nutritional supplements in addition to meals, than just going for high protein diets only.
Can I add something? As mentioned, the mobilization part, it's very important. It's one thing that the patient gets out of the SU and it's bed reason all day, and it's another completely different thing. The patient goes to the hospital gym or does very hard physiotherapy. So we must accompany that. When the patient starts getting real rehabilitation and getting, then we must give him more energy and more protein. So we have to see the patient that we have in front of us and see that in the beginning, we don't need to be so aggressive. And when he starts to move up the ladder and gaining the functional rehabilitation, then we have to hit high targets so that the patient can continue and to improve.
Another question about NRS 2002. Should this score be used for screening older adults also? Anna?
Well, yes, it could be used, but the tool dedicated to older people is the MNA. NRS is dedicated in general to all people, to hospitalized people, but the MNA is more specific because it contains issues about mobility, about neuropsychological problems, about the cultural circumference. So it's very specific for older people, and it should be used at first choice.
Thank you. And the hardest question for Imre, how to manage the patient's nutritional therapy to prevent post-intensive care syndrome and promote muscle recovery?
Well, I think this is one of the top research questions at the moment in post-ICU nutrition field. Like PICS is very complex. It contains cognitive, mental health, and physical impairments. And then, so the question is really on muscle recovery. I think, yeah, we really, really don't know yet, but I really hope that the research is moving forward, that we understand actually why muscle wasting is happening and to what patients it's happening the most. So which patients would benefit the most from an intervention? And then secondly, when can we intervene? Because clearly not all patients are responding to nutrition. So yeah, I think it's multifactorial. When can we intervene? Who is responding most? And then also mentioned by Ricardo before, I don't think it's a one-fits-all approach. It's probably a one-by-one approach, because nutrition is such a personal factor, with cultural and with all factors being involved during hospitalization that really impact nutrition, that I don't think there would be a one standard advice to prevent PICS. And again, PICS happens for months to years after recovery. So this extends to the home phase as well. And I think there's important tools where we can look at where the family engagement is really something which is really hot at the moment, really involving family members and caregivers in nutrition monitoring. So at least that we know what a patient is consuming. And if we know that it is not enough, that there's also room to ask for support, because I think it starts with signaling and monitoring actually what is really important in nutritional intake. So hopefully that answers a little bit of this complex question.
Yeah, thank you for the great answer. For Anna, another question. What is your experience with blenderized formulas?
Parenteral formulas or enteral?
No, blenderized.
Enteral.
No,
Enteral
yes,
formula.
enteral.
Enteral, yes. They are regularly used when enteral nutrition is prescribed. The most used and the most suggested are the polymeric formula because they are the most tolerated from patients. Also for infusion in the stomach and in the gut as well. So when it should be prescribed enteral nutrition, the first choice should be at polymeric formulas. They could be also palatable, so when the patient has some improvements in oral feeding, the same formula could be used also for oral supplementation. So I suggest this kind of a formula for enteral use, and I think it's best to use for this kind of patient.
Someone said that it's a bit confusing when choosing between PN and DEN. Is there any specific gap or sign which we should notice before initiating oral nutrition while transitioning from EN to oral?
Well, if the gut is functioning, enteral nutrition should be always the first choice. And if enteral nutrition is not enough, because for symptoms related to patients, it's not possible to increase the amount of the formula, then parenteral nutrition should be added. But parenteral nutrition should be just the third choice. So the first one is always oral, then enteral, and then parenteral. So it's true that enteral and parenteral nutrition can be together for the patient requirement, but enteral nutrition should be always the basis. And then parenteral nutrition should be progressively reduced.
Thank you. For all three of you, do you use indirect calorimetry in general ward?
Well, I think I can start. I use indirect calorimetry in the ICU, and I think it's useful, but I don't think it's as useful as some experts state. In the ward is different because one thing it's a patient that is bedridden, tied to the ventilator, and his status is similar during the whole 24 hours. Another different thing is a patient that either is on bed, either is seated, either is walking, that he can do exercise. So I think for bedridden patients, it's useful. For patients that are active, it's not so useful because you only measure for those 15 to half an hour time, and we estimate for 24 hours. But if the 24 hours are not homogeneous, then you will have a wrong value. So you think that patient is wasting this part, but if he's go to a walk or is does rehabilitation, it's a lot higher, and you can't measure it during the time that is doing rehabilitation. So I think it's useful for investigation and the ICU and in bedridden patients or right in the beginning of the ward phase. But when it starts with rehabilitation, I think it's not so useful at all. And I think it can trick us with thinking that patient is only using this one, and in fact, he uses a lot more calories than what we measure.
Imre, any opinion about this?
I think, yeah, I agree with you, Ricardo. So we use it in the ICU. I'm not aware of or of post-ICU studies. There's only a few. So I think in a study terms, it would be interesting to do. But in terms of clinical practice, we don't do it either in the post-ICU because it's quite challenging actually to put patients under a hood on the ward with all different factors happening all the time. So I think I agree, Ricardo, that's probably in the post-ICU phase not the main priority at the moment. But if you have equipment available, yeah, I mean, it's great to determine energy requirements, but it's also challenging. So I'm probably a bit in the middle.
Yes, I agree with Imre and Ricardo. And to have an idea of the metabolism of the patients, there are some formulas that can be quite accurate. For example, the Harris-Benedict formula that is more used in clinical practice because it's easier and accurate for the prescription of nutritional therapy. So yeah, I agree.
Yes, and we are waiting for future studies about indirect calorimetry on ward patients. For Anna, questions about fluids requirement and how to prescribe fluid in older patients.
In older patients, the most important thing is to encourage the spontaneous oral drinking. So to offer drinks, to be aware of the drinking amount of these patients, to provide support in giving drinks, in taking the patient to the toilet when they need, for example. So the first thing is always this. And if the patient is in a condition of some kind of dehydration, some intravenous fluid should be prescribed, of course, but that not should be the rule for older people, because if they could eat, they also should drink. And the first important thing is to provide drinks, to encourage to drink, to remind to drink. So it's a counseling for drinking as well. They could, sorry, I was just to add, they could always keep a diary for drinking to record the amount of the total drink in the 24 hours. That helps them to remind of drinking, and also the clinicians to monitor the amount of drinking per day.
And there are many questions about body weight. Which body weight should be used when calculating calories, energy requirements, and protein? Which body weight?
Actual body weight in the Harris-Benedict formula, but if the patient is obese, we should use the ideal body weight. So for a BMI of 22.5. If the patient is malnourished, still the actual body weight must be used because it's useful to prevent the refeeding syndrome, for example. So not to give too much calories and to be at risk of problems with potassium, phosphorus, and also cardiological and neurological problems. So the rule is to use the actual body weight. If the patient is obese, we should use the ideal body weight. That means for a BMI of 22.5.
And for resource-limited ICU setting, is there a recommended protocol for safely preparing these feeds if standard formulas are not available?
Is for me?
For Imre.
I really don't know.
Me neither. I don't think there are any recommended protocols.
I don't think there's. I know there's great work from Morocco, from Soumaya Tasdeli, I think is her last name. She, I think, has recently published something on limited resources and providing nutrition in the ICU. So for post-ICU, I'm not sure, but for prescribing enteral nutrition, that would be my guess to have a look.
Yes.
May I say something?
Yes, please.
Yeah, there is one more question. I think the main difference in dietary management of diabetic patients in ICU. I think this is for Dr. Anna.
Patients affected with diabetes, right?
Diabetes, yes.
Yeah. So as we can see, there are oral nutritional supplements dedicated for diabetes, so with a lower amount of carbohydrates. And in general, it's not suggested to prescribe low sugar diet or a weight reducing diet for these patients. So of course, diabetes should be under control with medications, with regular monitoring from the specialists, of course. But even if there's still diabetes for patients, oral nutrition should be always provided and suggested without a calorie restriction. So insulin could be used, oral drug could be used to keep the glycemic values under the rules, of course, but it's not suggested to prescribe a restriction caloric oral intake for these patients.
Thank you, ma'am. And one more question. Is astaxanthin safe for ICU or post-ICU patients?
Sorry, I didn't understand.
Is astaxanthin safe for ICU or post-ICU patient? Astaxanthin.
Sorry, I don't understand. What is it?
ASTAXANTHIN. Astaxanthin safe for ICU or post-ICU patients?
Can you please spell it? Because sorry, I can't understand. Sorry.
Yeah, sure. ASTAXANTHIN. IN.
I think it's an anti-inflammatory supplement, but I don't think there's any evidence really for not prescribing or do prescribing. So
yeah, it's a carotenoid with antioxidant properties, I think.
Okay. Sorry, I can't understand. I can't answer this question because I don't know.
Yeah.
Okay.
But what about, what about immunonutrition if we are on antioxidants? And what about immunonutrition? Is there any place in post-ICU patients?
Immunonutrition is dedicated for people that should undergo a surgical intervention for cancer of the gastrointestinal tract. These evidence so far are for this kind of patient. Immunonutrition is very useful. It should be prescribed before, in the 7 days before the intervention, and in the 7 days at least post-intervention, because it can help to reduce the length of hospital stay, the costs, and it could also improve the general outcome of patients. So for patients undergoing a surgical intervention, it's very useful.
Please, Koyal.
Yeah, there is one more question. When we can use adjusted body weight, because I know we use it when the patient is obese, but you said we should use the ideal body weight.
Yes, we should use ideal body weight if the patient is obese, because if we use the real body weight of obese patient, the estimation of his energy expenditure would be over the real need. So it would be very easy to prescribe a wrong nutritional therapy that is excessive for the amount of calories and also protein. That's why in this predictive formula, when the patient is obese, it's important to adapt his weight to an ideal body weight in order to avoid the risk of overfeeding, especially if the patient is not stable from a clinical point of view, and so the risk of refeeding syndrome is always present also for obese patients.
Thank you. And one more question. Many researchers say that high protein is harmful for post-ICU patients or in early critical illness. Is high protein good or harmful in such situation?
I can take that question. I think I addressed that already a couple of questions ago. There's really research showing that in the early acute phase, high protein is indeed harmful for some subgroups of patients. However, in the post-ICU phase, there's also some studies that I presented that when we tailor up to 1.3 to 1.5 grams of protein, we can reach nutritional adequacy. However, there's no really evidence showing what it does on clinical outcome or on, for example, muscle-related outcomes. So yet to be established.
Thank you. And one more question regarding ideal body weight. When calculating energy requirement for obese patients, should we use ideal body weight or adjusted body weight?
Ideal body weight is suggested.
Okay. One more question. I work in geriatrics and family medicine in Myanmar. Many post-discharge patients' family asked whether ginseng, bird nest, and local herbal supplements must be totally avoided, or can they feed their patients at liberal scale regarding the herbal supplements?
Regarding the oral supplements?
Herbal supplements, local herbal supplements.
Herbal supplements.
Herbal.
Okay, sorry, the sound is not proper. Okay, no, herbal supplements are not suggested from the guidelines because they could be also harmful for patients. It's not easy to control the effective role of the molecule that the patient could assume. So it's not suggested to prescribe this kind of supplements, but as you see in my presentation, the oral nutritional supplements that provide calories, proteins, vitamins, and electrolytes are the basic of the nutritional therapy for the older people and for malnourished people in general.
Thank you. And one more question. In a post-ICU patient recovering from septic shock with prolonged vasopressor use, how do you individualize protein energy delivery considering mitochondrial dysfunction, persistent inflammation, and risk of refeeding syndrome? And adjusting for indirect calorimetry and anabolic resistance is also important.
I think I can take.
Recovering from septic shock.
Yeah. Yes. So when the patient goes to the ward, and this kind of mitochondrial dysfunction and persistent inflammation that can last months, but usually it's starting to get down because after we get the acute phase, we have some persistent inflammation, but the level of inflammation is not usually that high. But along with the tailored prescriptions, usually start with the lower and we increase gradually to see if the patient can handle it. So there are signs that if you can handle it or not. One of that is the refeeding syndrome that you talk about. About the refeeding syndrome, it's usually about the body not handling enough the nutrition that we have, and usually it's with potassium, phosphate, magnesium, and so on. So in the patients that I think they could have or will have refeeding syndromes, I act preventively. I start low and increase, and I treat aggressively for the ions. I push potassium, phosphate, and magnesium to higher levels if they are not in AKI, and so that I know they will go down, but I have a safe margin for them to come down, so that they can handle and they can try to see. The other is we can try and see the kidney function. If we give them higher proteins that they can handle, the urea will start to increase. The creatinine will also try increase, but in a slower ratio, and we'll see a gap. And there are some studies using the urea creatinine ratio to see if there's the proteins being used or not, that we can try and use to tailor the nutritional support. And I don't see if anyone.
Thank you so much. And one more question, please enlighten about prebiotic and symbiotic in ICU patient.
Sorry, I didn't understand it.
Dr. Imre?
I don't have any experience with prebiotic or symbiotic. We don't prescribe that in the ICU.
Okay. And Dr. Anna?
Yeah,
is there any technique?
Me neither. I don't, yeah. No
Okay.
experience.
Okay, fine. I'm moving forward. In case of sarcopenia, how much protein should be given? Which type of protein is useful? Any other supplement could you recommend for sarcopenia?
Well, the guidelines suggest at least 1 gram of protein for kilogram, but in case of sarcopenia, the minimum is 1.2 gram of proteins for kilogram to 1.5 and also 2 gram of protein per kilogram per day, according to the characteristics of patients. And sarcopenia, of course, benefits from the a bigger amount of protein per day, and also with some dedicated exercise to improve and make greater muscle mass. So there's a synergy between nutrition and physical exercises.
Okay. And one more question for Dr. Anna again. You spoke about immunonutrition for cancer patient, but can it be given in other condition to reduce the oxidative stress?
As for now, there's no evidence that immune nutrition should be prescribed in other settings that cancer patient that should undergoing surgical intervention. But of course, there are studies, and maybe in some years we can have other evidence to prescribe immune nutrition.
Okay, thank you. One more question regarding refeeding syndrome. Usually we start at 10 kilocalorie kg per body weight. However, if the patient still have hypophosphatemia by day 3 in ICU, do we increase or maintain the calorie?
If the patient has hypophosphatemia, this level should be at first regularized. So before prescribing the nutritional therapy, all the values of the electrolytes, in particular potassium and phosphorus, should be in the normal range, because it's a high risk for patients to develop increasing problems about the neurological field or the cardiological field, and so the refeeding syndrome, if at the beginning all the electrolytes are not in the normal range.
Okay, and the last question, I think it has been discussed regarding fluid calculation. I think that has been discussed already.
Yeah.
So I think no more question. We covered up everything.
Okay, so we are also at the end of the time for our webinar, a few minutes later. It was an impressive participation, and I think you took more than 40 questions. So great job. Before concluding, I would warmly like to invite all speakers to share the final remarks.
I can start. I think it was a great webinar. Really a lot of interesting questions, and really happy to hear that there's so many practical questions as well as what to take home. And I really hope that I convince you that there's still a lot to be discovered in post-ICU phase, but I still think that there's room for nutritional therapy, and we can really improve outcomes for our patients here.
Yes. I also like to thank Eman for attending the webinar and for the wonderful questions that were made. I'm sorry for that one that I skip in the middle. I would just like to highlight that the nutritional support must be personalized with the patient. You have guidelines, you have options, but you must choose each option for each patient. And you have several routes, oral, enteral, and parenteral. And I think that the guidelines are straightforward with going from oral to enteral to parenteral, because more of safety issues and risk of complication, because parenteral is the one that has most. But if the patient is in oral nutrition or internal nutrition and that's not enough, you can start parenteral. If you use parenteral nutrition in lower doses or just a small bag of 500 milliliters or 500 calories, is safe. it's usually very safe. Only when you go higher doses of parenteral nutrition that the complications starts to arise up. So if you're, don't be afraid to start a small bag of peripheral or even central line parenteral nutrition, because it is safe. In the beginning it's safe. When we escalate, we have to be more careful. We have to do more calculations. But for supplemental and the beginning, usually safe, and it's a good option. If the patient refuses to put nasogastric tube, that was one of the questions, I would do parenteral nutrition as long as it is in the hospital. If it's at home, no, the risk is too high. But if it is in the hospital with specialized people that know how to use parenteral nutrition, yes, it's a good option. So tailored nutrition for your patients and see if you can adapt.
Thank you very much. It's been a pleasure and an honor to be with you today. I'm very happy to see how many people are interested in this field and how many questions we received. So also from my part, the general message for you in your daily work, in your daily practice, is the importance of nutrition and of oral nutrition. So even if the patient should undergo enteral nutrition therapy or a parenteral nutrition therapy, the basis of nutrition is always oral, of course, when it's not contraindicated. But if the patient could eat because its gastrointestinal tract is functioning, please provide food for patients, of course, individualized foods with the help of a specialized dietitian, of course. So we always work in team. But it's important that patients keep eating and keep working their gastrointestinal tract. So it's very important to keep in mind this and to provide food and encourage people to eat and drink alone, because it's the best for our patients.
And also, if Christian or Koyal has something else to add.
Thank you very much, Alina, for make this webinar possible. Thank you for all the attendees and for the great questions, and of course for the speakers for their great talks.
The same thing. Thank you for this global opportunity to upgrade ourselves. And I think the medical science and nutrition science both are the best amalgamation for patients' outcome, right? So thank you once again, and congratulations to all the early career faculties of EFIM and ESPN. Thank you.
Now it's my turn to say the final thanks. Thank you very much for all our speakers for the excellent and insightful presentation, and to our moderators for the guiding this discussion. I would also like to thank Professor Clegg, Chairman of ESPN, for making this webinar possible, and also to all ESPN members for their participation and support of this joint initiative. On behalf of the EFIM, the European Federation of Internal Medicine, it has been a real pleasure to host this webinar together with ESPN. We hope that today's session has provided practical insights, and I'm sure actually it has. EFIM has ongoing the development of sarcopenia guidelines. We have a lot of initiative on comorbidity patients where we talk a lot about nutrition in these patients, because internal medicine is like joint specialties like gastroenterology, we are endocrinology, we are from different fields. I'm from immunology, for example. So I think that the information provided today will support our daily clinical practice. Thank you all for joining us today, and have a very nice afternoon. Bye-bye.
Bye.
Bye. Thank you.